Hello, my name is Dr. Bonnie Key, and I'm the editor-in-chief of JACC Cardio-Oncology and the founder's associate professor of cardio-oncology at the Perelman School of Medicine at the University of Pennsylvania. I am very happy to be joined today by Dr. Juan Lopez-Mattei. He's the director of cardiac imaging at Lee Health System in Fort Myers, Florida. He's JACC Cardio-Oncology's social media director, and he's a member of the ACC Cardiovascular Imaging Leadership Council. He is also the first author of a primer we were very pleased to publish in our December 2021 issue of JACC Cardio-Oncology, entitled Cardiac Computed Tomography in Cardio-Oncology, along with senior author Matt Budoff. Juan, thanks so much for joining me today.
Thank you, Bonnie. I'm really thrilled about doing. I was thrilled about doing this. I appreciate really giving us the time to talk a little bit about our article, and we're very excited.
And I appreciate you and Matt's and all of your co-authors. Excellent work. For our readers, in your view, what are the 3 to 5 most important take-home messages? If you want them, what do you want them to walk away with in reading your important piece?
Definitely. First of all, I want to thank my co-authors. And Dr. Budoff. This was a great experience. But the things that I want to really for people to keep in mind and to hopefully they get from the manuscript is or the highlights is the first thing is that cardiac CT and its techniques can help us detect subclinical atherosclerosis. Now we know that calcium score is in the realm of cardiac CT, but we know that in non-gated studies, it can be quantified and it's prognostic. So one of the things that is important is to keep in mind that these patients have a lot of scans and they can look at the coronaries and quantify the calcium, especially it has to be in the non-contrast CT, of course, but it's important to consider that. Also, another important point is that in this context of cardiotoxicity, where if there's a clinical picture that is a little bit complicated, in the sense of having a clinical presentation that is similar to ACS in low to intermediate risk patients, definitely cardiac CT can rule out obstructive coronary disease. And the third point that I want them to consider is that CT can help when cardiac MRI cannot be used to assess for cardiac tumors and pericardial disease and cardiac function. So it can be as an adjunct, and in some cases, it might be needed. So these are the 3 points that I think are the most important.
Those are excellent take-home points, Juan, really. So we can really leverage CT in our cancer patients because they are getting a lot of scans. So focusing on the non-con CT scans to look at calcium, also using it to exclude obstructive coronary disease, and then also using it, like you said, to evaluate cardiac mass is also very good for pericardial disease, as you stated, particularly in some instances where not all other imaging modalities may be available, but also, as you said, as an adjunct. So great points. Let's take a deeper dive in cardio-oncology specifically. In what instances have you found CT to be most useful in your patient care?
Definitely. So I think that the concept, and this is something that that I've been really happy working with you and others for the SCCT consensus statement that we're working on, that hopefully is going to be out soon. Where we want to emphasize the importance of detection of subclinical atherosclerosis, because we know that there's an excess mortality of cardiovascular disease in our cancer patients. And this could be due to shared risk factors, toxicity from cancer treatments, and other things. But I think it's important to really emphasize that the calcium in the coronaries or even atherosclerosis in the aorta cannot be ignored in a scan, in a cancer scan. So one of the recommendations that we're trying to, at least in that consensus statement that will be available soon, will be to really focus on coronary calcifications and not ignore them, because let's say there's a patient that has a stage, 3 malignancy, and the tumor is well described and everything, and maybe they're on some sort of treatment where the patient is going to live longer than, because we know that there's a lot of great cancer therapies that have prolonged the survival expectancy of these patients. But if the patient has a lot of calcification in the coronaries, that's going to become a problem. Or even patients that are the survivors, which is even more important, someone that is on remission, that we're just scanning the patient because of some reason, some suspicion or something, and then patient has a lot of calcium, but if there's not a statement, at least making aware the oncologist or whomever is looking at the scan that this patient has calcification, it might not be even part of the clinical history. And this subclinical atherosclerosis, I think, is something that we don't really want to miss if we have the information there.
Yeah, great point. Great point. Tell me a little bit about grading of calcium on these scans that are not necessarily designated to be grading the calcium, that they weren't ordered for that purpose. Tell me a little bit about grading and what level of coronary calcium would you start, for example, a statin therapy?
Definitely. So there are ways. So the thing is that there are ways that you can quantify without having a gated scan. If you are able to, if you want to quantify, use the quantitative approach using the Agatston score. That's something that has been validated. Of course, it's not as accurate as a gated scan, but it's pretty good. And we're talking about, usually the recommendation is if someone has a calcium score of 100 or more, statin should be a consideration. And this applies to non-cancer patients, because most of this data, of course, is not has not been considered in cancer patients, just the general population. But there's other ways to quantify calcium score, like using the visual approach. And what I'm talking is about the method that has been developed as a consensus from the SCCT, which is the CAC DRS, which is this method where they recommend either to use the Agatston score or the visual score. And with the visual score, it's just assessing whether the burden of disease looks mild, moderate, or severe. And they in the Hedge et al., they provide very good examples on how you quantify visually the calcium score. So I think it's important to also be aware of that, and that ideally, it will be good, this is in the ideal world, it'll be good to have the scan with the staging of malignancy or whatever the purpose is. And then, maybe a side note or within the same report, CAC DRS and whatever the number is. Because, as you well know, we're caring for these patients, and there's a lot of things that sometimes when the clinical situation becomes complicated, we have to think, well, is this toxicity, or this is something else, or this is a coronary situation, a lot of troponin elevation and other things. So I think that having the knowledge of at least if there's something there that we have to consider, or if there's something there that is not being treated. So I think that is very important to consider the CAC DRS in that context, in the context of non-gated images. Of course, there are other technologies that CT has to offer, but one of the focus is mainly this, because in current practice, we're not, in most places, they may either mention it or not, and we need to standardize that practice of, whomever is reading those scans, that they at least say something about the coronary calcifications, either not visualized or visualized. At least that will be a big change.
A very important point, I think, Juan, as you stated so eloquently, the need to standardize reporting and point out CAC and point out the subclinical disease. And it's a great thing for our fields to strive towards together. So I look forward to that and look forward to your leadership in terms of pushing that forward. Last question. What do you think are the most exciting advances in CT as it relates to cardio-oncology? There's a lot of novelty out there in terms of techniques and analysis. What's most exciting for our field?
So I think there's a couple of exciting things, techniques. I will say that FFRCT, has been shown to decrease downstream testing, because one of the things that people have noticed when they're using coronary CT is that sometimes it could, in some ways, it could increase downstream testing because this lesion, we're not sure. And it happens with invasive angio as well. That's why in invasive angio, you have the different coronary physiology techniques to assess for the significant hemodynamic significant obstruction. So FFRCT is similar in some ways, where using this modeling, they can determine whether the lesion could be functionally significant or not. And that, in a patient that is a bit more at risk of developing any other, I think that the important thing will be to consider something less invasive. And if you have the CT plus the FFRCT, I think that will definitely decrease all these invasive procedures in a patient that might not really need them at all, and maybe they have an intermediate lesion, but then the technology or this FFRCT shows it's not functionally significant. Then I think that's a win. The other thing are all these AI-based methods, like plaque quantification. I mean, there's even automated calcium score quantification. I mean, there's a recent great paper in JAMA Oncology, if I'm not mistaken, that they found that using that technology of automatic calcium score in the treatment plans in radiation therapy of radiation therapy, which is a non-contrast CT with low resolution, but still they found that it helped prognosticate patients that underwent radiation therapy. So I think that's valuable. And also the plaque quantification with with contrast CT that is also being looked at. Like this company clearly, which there's going to be more people, doing that for sure. There's still more vendors getting into that, where you can assess the progression of the plaque. That's of importance in patients with undergoing radiation therapy. And I think that could be potentially an important technology to monitor for these patients. And I mean, there's many like dual energy CT. I mean, there's many other developments, but I think to me the most important are these AI plaque assessment methods, and also the FFRCT. Those I think are very relevant to the issues that we have with our patients.
Great, thank you so much, and certainly a lot to look forward to in the field of CT and in cardio-oncology. Juan, I want to thank you so much to you and your co-authors, to Matt Budoff, for your excellent primer, and thank you for all your leadership in the field. Thank you.
Thank you, Bonnie. I want to thank, Eric Yang, Lauren Baldassare, Susan Dent, Matt Budoff, Maros Firstnik. I mean, we had a great team, and I think I love the product, and hopefully we can continue to advance this part of the field, which I think is very important in our patients.
Great. Thank you.
Thank you.